hospitals were to procure from an agreed list of commodities from pre-qualified vendors at agreed competitive prices. And this was sourced from one of MOH's reports 2021. The establishment of an electronic logistics management system, ELMIS, to derive reliable and timely data to guide supply chain decision-making at higher levels. And subsequently, GILMES and others have also come to solidify the face of the supply chain. In the healthcare front, we can identify three main challenges with pharmacies, with hospitals, pharmaceutical companies, and patients. And these include stockouts, delays in supplies replenishment, lack of convenient and cost-effective fulfillment options, rising counterfeiting and regulatory changes, along with persistent need for better drug cold chain management. These struggles are inconvenient, adversely impact the quality of care patients receive, and increase staff stress levels. So how can healthcare supply chain professionals triage these concerns? It's only through a resilient supply chain system. COVID-19 also came. It affected a number, virtually broke down all the supply chain systems. But again, it also came with its advantages. We realized that after all, we are not as strong as we assumed ourselves to be. And we started thinking of strengthening and building a resilient supply chain. And to build a resilient supply chain, it is essential to ensure that the supply chain is flexible, adaptable, and responsive to changing circumstances. So it's not a one-way matter. It changes over time in relation to what the changes or dynamics of the environment are. And the World Health Organization recommends that countries should focus on strengthening their supply chains by investing in infrastructure, technology, and human resources. But in our supply chain, as at today, anybody at all can be a supply chain practitioner. Put him there. The focus is shifting from efficiency. Now it's not only efficiency, but also to resilience. You can save costs, but at what expense? Resilience is the ultimate, because you save costs today, there are disruptions to tomorrow, and your system will collapse. But we want a system that is efficient and that can also withstand the disruptions in the environment. Now, when we talk of a resilient supply chain, what does it look like? It is the one that has an end-to-end visibility. It allows for digital transformation. It also has the property of shorter planning cycles. It studies risk and offers risk mitigation. It allows for remote work preparedness, sustainability, engaged leadership. And one of the observations I've made when I was within and now that I'm without is that leadership commitment in the area of supply chain is anything. Sadly, that is where leadership also fetches all the money to run their activities. So invest in resilience. And remember, resilience isn't just about surviving disruptions. It is about thriving in the face of challenges. Now, what are the prerequisites of resilient supply chain. Building a resilient supply chain to support universal health coverage requires a multifaceted approach that involves political commitment and government leadership. Chief Director is gone. I was going to dedicate this session to the Minister of Health and his team. Clearly define governance structure and build leadership teams to support supply chain management. It appears, underlined, that the governance structure for supply chain management in the ministry is weak, if not non-existent. Apart from the two directors who are seen as leading, I cannot see the input from key directorates like PPME, like financial controller. Because if financial controller does not know what is happening in supply chain, how does he allocate funds to support supply chain management? Dr. Boateng is here. Carry it to your boss, PPME. Take interest in supply chain management and allocate resources accordingly. Again, it should build systems, streamline and digitize essential supply chain processes, including procurement and making them transparent. When we talk of supply chain, people tend to limit it to just the distribution of the commodities. But supply chain begins from manufacturing, through procurement, warehousing, distribution, until the product is in the hands of the user. All the key actors there are players in the supply chain, in the supply value chain. And each one of them is important if we want to consider resilience. Investing in infrastructure, warehouses, handling equipment, transportation, application of innovative approaches and technologies, provision of human resources in numbers and mix. Not everybody at all. Get the numbers, but also get the right persons to be able to lead, to be able to run our supply chain systems. People come for national service and they are managing hospital stores, facility stores. The risk associated with that arrangement, I'm not sure management have calculated it. Because these are not permanent members of the system. So if they run away, they divert commodities and run away, who do you hold responsible? National Service Secretariat or who? Establishing strong partnerships with stakeholders across the supply chain. Importantly, use data and automation to ensure sufficient supplies of critical commodities and medicines. We now moving into evidence-based decision making, decision based on data. We need 100,000 pieces of a product. The evidence is that this is our minimum stock level. This is our maximum stock level. This is our reorder level. The product has fallen below reorder level, and therefore we need to order 100,000 to reach maximum. This simple arithmetic and mathematics should guide all our decisions in our warehouses. Again, establish and enforce effective facility access procedures. We look at the health system with tertiary. Now we have quaternary, tertiary, regional, district health center chips. But there is no restriction as to where one can go for service. So you go to a health center and the health center wants to serve particular products because its clients come and their disease pattern shows that these are the products that they need. It doesn't help the supply chain system. So we need to manage that carefully. Then respond to orders for help in a coordinated way. Yes, I've seen the donations policy of the Ministry of Health. Very good on paper, but who coordinates it? A facility or a region endowed can receive multiples of donations. Whether it is in excess of their use or not, who manages? So you move into some of the regional medical stores, they have items that they are keeping on corridors. And sometimes in open air, because they do not have immediate need for them. You move to others, and they don't have any in stock. There should be a system that will enforce effect, that will respond to offers for help. If any donor is coming, you direct them to where the need is and not where they think they should take the items. Then create value through digital transformation. Develop a financing system that is able to respond to the supply chain need in normal and crisis times. And monitoring the performance and provision and providing supervision to the supply chain. Sometimes when you call some of the officers in service, they say, oh, they are going on monitoring. And we say, what are they going to monitor? They go to do hello visits because you get there, they sit you down, they ask you your mission. By the time you finish telling them what your mission is, it's lunchtime. They take you to lunch, they buy you some malt. You look at your watch, it's already 3:30 and you want to come back. What did you go to monitor? There should be a system that polices our supply chain processes. A system that follows up on what is happening. Apart from the technology that we have, human beings should also move and look at the challenges that people on the floor are facing so that they can provide answers to this. Develop, I've said it, develop a financing system that is able to respond to it. So now I'll look at my key conclusions. The chairman said he's giving me 20 minutes, so let me. Universal health coverage is a critical goal for nations striving to ensure equitable access to health care for all. That one is non-negotiable. Everybody understands. A fundamental component of achieving UHC is the establishment of a resilient and sustainable supply chain that can guarantee the continuous availability of essential health commodities. The role of visionary leadership, innovative technologies, and securing adequate financial resources in driving the necessary changes and improvements in the healthcare supply chain cannot be underestimated. Adequate funding provides the financial backbone for supply chain resilience and sustainability. It balances risks, investment, and strategic decision-making to create a resilient ecosystem. Infuse sustainability into each intervention to ensure a strong government-owned and finance supply chain using dedicated staff, coordinated systems, and innovative technologies. According to the World Health Organization, building health systems resilience towards UHC and health security beyond COVID-19 requires, and I quote, a renewed and heightened national commitment to make countries better prepared and systems resilient against all forms of public health threats for sustained support towards both universal health coverage and health security. Building a resilient supply chain is crucial in today's complex and volatile business environment And if we want to achieve a resilient supply chain, government must invest in the 4 pillars of resilience: visibility, flexibility, collaboration, and control. Ladies and gentlemen, I'm done.
Thank you so much. Thank you so much. I will call Dr. Fred to quickly take us through the second presentation. After that, then we'll take a few questions before we wrap up the session. Thank you so much.
Thank you. Good afternoon. There is no service that you hear a lot of acronyms than Ghana Health Service. DDCC, DDF, DDPH, there are many. And today we are also hearing a lot. End-to-end visibility. Okay, so I have the opportunity to do the next presentation. And mine is quite simple and faster. Can we project? So I am doing the effective leadership and governance for supply chain excellence. And we will go through the background. We do a bit of the regional profile. Look at the challenge that we faced in the creation of the new region. And we are going to look at the challenge in terms of the warehousing, the ICT, and distribution. This presentation is now about manufacturing, as Dr. Ade Doko said. We are not yet there. We will look at activities that we have been able to carry out so far, and then the milestones. And finally, we will talk about the support that we need. Then we conclude. Bunei is one of the biggest, actually the biggest region of the newly created regions. And it was carved out of the Down Bunei Ahafo during 2019. In fact, as a regional health directorate, 19th November will be 4 years. Let's move on to the next one. In terms of geography, Bunei is 2/3 of the Down Bunei Ahafo region. And in terms of land size and mass, it's about 10% of the total country. Next to Northern region, Savannah, Ashanti, then Bunei East. And you can see the location. By location, we are actually bordered by 6 regions. But let's look at the rural communities. The next slide. Mostly, we are a rural community. And most people are actually engaged in farming and retail services. The capital, Techiman, is a nodal city. And then a lot of trunk routes from all these areas come in there. And therefore, that leads us to the risk profile of the region, which is the next slide. The region houses large food markets, including the Atebubu, Techiman, Kintampo, Yeji. And I always say this for people to know. When Greater Accra and Greater Kumasi were locked down during the COVID-19 pandemic, people still find their way to come to Bunei because of these commercial areas. And so, as a region in the middle of the country, these population dynamics have immense public health implications. Public health emergency happening in anywhere in the country, we will get some by virtue of our location. And I always want us to see the graph of the next slide, please. So you see the location for Bono East. And for those of us who don't know, the Regional Health Directorate is not situated in Techiman, it's in Kintampo. It's in Kintampo. So you see the graph or the profile for Bono East. We are also bordered by the Volta Lake. I have some pictures to show. Let's go to the next slide. In fact, we have been affected by the current flooding. And this is what you see in Bono East by virtue of our bordering. Next slide. You can see some of the community submerged with this current flooding that we are having in the country. Okay. And you can see where we plied our trade. Next slide. And this is about 60% of our routes are like this. We were actually trying to get, this is not potholes, they are manholes. We were trying to capture, but this is the best that we could capture in terms of when you are moving from one end of the district to the other. Next slide, please. So this then leads us to the problem. You know, politicians, governments take decisions for various reasons. But for this particular one, if you look at Bono East, if you look at the then Bono Ahafo, is the most deprived of the three other regions. And we have been having a lot of frequent stockouts, and not only that, our inability to receive all the requested commodities. This is compounding the indebtedness that some of the facilities are having, and therefore doing a lot of emergency buying. But when we were carved out, the Director General decided that we set a coordinating team for Bono Ahafo and Bono East, for Oti and Volta, for Savannah, for Northeast, for Northern Region. And so a lot of us don't know that there has been a declaration for us. Next slide, please. And this is the DJ's letter. And we were supposed to see how, as a region, we coordinate the regional medical stores. For though we have been carved out, but we still receive our commodities from. And I intentionally decided to bring, this is dated 4th December 2020. And that comes with the famous Ken Declaration, where we have all the deputy directors, administration, chief pharmacists, regional medical stores, and other from our big brothers to go and decide how we will coordinate and manage the medical stores for all of us. And I term this one the famous Ken Declaration because that's where we had the meeting. At the end, this is what we came with. We proposed a coordinating team in the running of the supply chain for the new and old regions. And these were supposed to be the coordinators: deputy directors, administration, finance, chief pharmacist, regional medical stores, and then regional medical stores manager. They were supposed to have quarterly meetings. Let's move on to and these were the roles and responsibilities, terms of reference that this coordinating team was supposed to produce for the regional directors to take decision in doing that. We will skip the reports. I don't know if any of my colleagues, regional directors, have gotten any of these reports for the past 3 years. For what I will say, Bono is Ahafo, and then Bono, we met once, and that has been the end of that meeting. Let's move on to the next slide. So these were some of the outputs and the reports and the requirements that we were supposed to do. Next slide. And not only that, the other supports that we were supposed to receive are these, based on the Ken Declaration. But fast forward. Next slide. With all these measures that were put in place, let's look at some of the effects of the commodities for Bunuis. And I decided just to use the harmonized health facility assessment because that one is actually providing us external validation of what is there. So I decided to, and we won't go through, there are many, but we'll just pick few and then skip for us to see. So if you look, and I decided to choose some of them. So look at emergencies, salbutamol. For national figure was 24%. Ahafo is having 23%. Buno is 32. Buno 32. And Buno is 17%. Look at the corticosteroid inhaler. The national was 8%. Ahafo 7%. Buno 11%. Buno is 1%. I just want to pick some of the commodities for us to see. So let's look at amoxicillin. Let's move on and please go on to the next slide. Next slide. Okay. You know when we come to our facility and they really want to lambast your facility, do you know the term that they will say in Mekor Hospital, Paramenyebi? In fact, that has been an indicator for your performance as a facility. So let's look at that. The national figure is 74%. Ahafo is having 55%. Bono 68%. And Buno is 38%. Let's move on to the amoxicillin. Then we can move on to the next slide. Okay, so this is, let's go back. This is also very important when it comes to the oral rehydration salt. National, the figure was 69%. Ahafo 94%. Bono 95%, and Buno is 66%. Let's look at zinc sulfate. Somebody said something. He said when there is too much inequities, it will lead to what? Iniquities. And when there is too much iniquities, then the sins are not pardonable anymore. But that's the joke. So let's move on to the next slide and then see the amoxicillin. Folic acid. Let's move on to that. So let's look at the mean proportion of all items at facilities. The national was 39%. Ahafo was 42%. Bono 46%. And Buno is. We'll end with the statistics. And then let's move on the decision that we decided then to make. Please, let's go on to the next slide. So looking at all these issues, we started to do introspection as a region. Within the low foods that we could really handle and make do with. So these were the things that we came at. Look, the Bunuis is already having, we're lucky. We're already having an abandoned medical stores already there. So that was something that we could do something about. We also had the full complement of the core managers. We have regional supply officer, we have regional procurement officer, we have chief pharmacist, we have almost all the complements. So what was then keeping us looking at these? And the reason why Buno East was also carved, if you are moving from Sunyane to Kintampo, it's about 2 and 3 hours, roughly about 3 hours. From Kintampo to Sine West, it's about 4 hours. So if you're even talking about lead time and for cost, then it means that if you have a warehouse at Kintampo, it makes every sense. And in fact, that's the reason why these were really created. And there was strong will or goodwill from partners also then. So let's move on to the next slide. We did a lot of stakeholders consultation. A lot. And then it was around these pillars. The warehouse, information, distribution of commodities and human resources. So let's look at some of the pictures when we did the assessment to inform us the decision. So this was the abandoned medical stores that was there already. Let's move on. And this was there for us. Let's move on. This is outside. And it was having these materials, papers, and all these. Let's move on. Let's move on. So I intentionally go back. I intentionally brought this picture because the man you see in the middle is the then regional minister for Bono. After we did our tour, and the last one, if you could come closer you could see his face, and I could read that, look, this man, he will help, but maybe in about 7 years to come. So let's move on to the next slide, what we decided to do then. So the idea that I should site my office at the regional medical stores was abandoned. One. There's also another facility. We also abandoned that for the reason that, look, if I started operating my office at the medical store as a single person, almost everybody will come and we will do this. We will do that. For all you, then that we will use that facility when it's needed. We cannot really use it. So I decided then to share office with the municipal director. So every day I go to work, she's there, I'm also there, we are working. And then also use some of the complex that she was having as pregnancy school for some of our offices. Then we told regional health directorate, Ashanti region, to look at how, if we wanted to start, the ways that we go around it. So let's move on to the next slide. And so you see the meeting with my hands there. I was just thinking, so how are we going to survive? And it was there that I have to break the news for the decisions to take. The next slide, please. Then this is the tour that we took to the Ashanti region. Then the next slide, we invited Director SSDM for her also to give us the technical advice in the business that we were trying to venture. If it was possible, feasible, and if you really had the backing of the DG. Let's move on to the next slide. So we had an assessment from Kimonix. They came with the tallest to come and assess us and see whether we could really start the medical store or not. And then it was agreed, like, let's begin to work and then optimize the warehouse. So we started the work with a lot of support from partners. We will see. So let's move on to the next slide. So this, we began to work with support from others. Let's move on to the next slide. Let's move on to the next slide. Let's move on. We're working. And this is what? It was becoming beautiful, isn't it? So let's move on to the next slide. Let's move on to the next slide. Okay, the next one. In terms of human resource, we've already discussed. Look, we had the complements of all those that we needed really to make this work functional. All of them are there. And we have also realized that we had a lot of enrolled nurses around who were living around Kintampo South that we can relocate to come and work at the medical stores to help us as we look going forward in terms of mechanization. So all these we did. Let's move on to the next slide. These are the men and the women. We have the men and we have the women. Okay, so let's move on to that. So you have all of us here. Let's move on. Let's move on there. So this is the current state of the warehouse. Let's move on. Won't you clap? You have to clap. And so let's move on to the, well, and finally, on the 31st, 2003, all the stakeholders who have come, who have helped us, came, really. So you see all the partners in there. Let's move on. Let's move on. It was a happy day. Let's move on. So in terms of, and we were working around the clock, developing protocols for all these. So Saturday we are there. What protocols do we need for LMD, for Gilmes? All that we were working there. Gilmes, so we had a lot of training from UNFPA and others to train our staff how to use the Gilmes. And this, all our facilities are on board. We receive laptops also to help us in the logistics. So let's move on to the other slide. And these are the laptops that we receive. And this is Gelmish training. Cosmos and Sarafina. These people, they don't sleep. They are always working. And Gelmish, Cosmos, we are happy because it's a national facilitator for Gelmish. So that is what we have also been using a lot in developing this. And the supply governance, so we have also initiated the supply chain working group, and this is the meeting I was going to. Let's move on. That's the training that we had. Let's move on. We have done our tenders. And not only that, we have evaluated the tenders. So let's go on. Let's move on to that. The LMD support. I think Director SSDM said, through the support of GHS, we have been able to award the contract to the 3PL, Skynet. They will come. We have already done our routes already. And actually, we have been weighing off from Bunu East when it comes to the LMD. Because we are yet to conclude that with our colleagues from Sunyani. So these are the things that we said that we will do. Facilities within the Bunu East were trained. We have done that. Skynet, we have done. Okay, so let's move on to the next slide. And this is one of the engagements when they were really taking us through how we are going to actually use the LM. This is the first meeting that we had with them. So next slide. Okay, so the question is, what's next? What next? We have done all. And today we have heard no product, no program. No matter what you have, if the commodities are not there, then it means that still Bunu East is not viable. Unless we have the medical stores in Bunu East operating, then the very reason for which Bunu East was created has not been achieved. And not only for Bunu East, for all the other 5 regional hospital districts, regions that we should look at. So the question then was, what next? Then we have awarded the contract. We have to sign. We started engaging the partners through DJ. So DJ said, okay, he's made a commitment. We should also look and see the other partners. And the questions that we're asking, how are we going to capitalize the medical stores? How are we going to get the seed money? Who is going to give us that money? How do we service the indebtedness to Sunyani? And above all, what is Bunu East going to commit to this work with what we have as part of the medical stores? Because almost we have done a section of it which can virtually pick all the things that we have. Then the questions that partners kept asking us, what measures are you going to put in place to ensure safety, availability, and also financial sustainability? So let's move on. And these were the engagements that we had with USAID. When after we have done and we're ready to sign the contracts, we came to, and USAID, they asked us, so what are other partners bringing on board? Because they want transparency. They also want to see before. Then we went to UNFPA. We came. UNPA, we came there, and then we also had discussions with the rep. Let's move on to the next slide, and the next slide, and let's move on to the next slide. So these are the actions that we have taken so far. We gathered all the suggestions that you gave us, went back, and then we have come up with a plan. Now, a team made up of 2 internal auditors, finance officer, and a supply officer, and a pharmacist. They have been tasked to look into what caused the indebtedness in the first place. That is one. And two, how are we going to service that indebtedness? And three, what are they going to contribute? That is the basic things that so that when we move on, we are not going to face and saddle with the. Bruno has also been with us all along. In fact, we have discussed a lot of initiatives. How are we going to win off? How are we going to settle the indebtedness? What support is Bruno going to give us, Sunyan going to give us? And when are we going to agree finally so that our facilities will no more go? Because the discussion is that they have already procured for the last quarter for Bruno. It's fair that we really agree and then make sure that, because they actually procured with us in mind. The good news that we have is that DJ has made commitments to this program as we go forward to sign the contract. I didn't want to show a letter, but there is an official letter which was written to Sunyani and Kintampo, giving us the blue light to go on and then take steps to officially win off from Sunyani by 31st October. So all this is having the support of DG. We have engaged all partners. They have told us all the support that they are going to give us. For transparency, we'll come to all the partners and let them know what is on the table. That this is what this partner is coming. For honesty. So we'll come back to you, tell you what the facilities are also going to do. The other things that we need, that some have, we need a pickup for the regional medical stores. We need a new one. Because one of the things that really came up during our discussions with the finance officers, the medical directors, the district directors, was the gap in supervision. And you can't blame anybody. Look at the topography of the region. So for us really to put our eyes on what and increase the supervision, there is a need for us to get a pickup for the medical stores. In conclusion, the very reason why Bunelis was created was for access and commodity security. 4 years along its creation, access is still worsening, and the status quo for which it was created has not been addressed. The service Buno region and partners have supported to the final leg of the operation. The region will need all support to be viable and maintain viability as we put in mechanisms and structures for sustainability. Let's see some acknowledgement here. Acknowledgement, next slide. So we want to acknowledge DJ because it was DJ's tour one day that he was summoned to go to Accra. Then we actually advocated and took DJ that, DJ, come and see something. So the moment he got to our medical store, he said, Fred, what are you waiting for? Use it. And then Director SSDM has been providing unprecedented support. UNFPA have been amazing in our warehouse of optimization, support. Global Fund have been amazing in all the things that we are doing. The pictures that we are showing you, next year, when we are presenting, all the ceiling will be long span. All the ceiling will be long span because we have support for all these WHO, medical directors and district directors, regional directors. Thank you.
Thank you so much for the excellent presentation, one at a higher level and the other at the operational level. We've seen progress made in leadership and how actual boots on the ground can help to improve supply chain. Because our time is fast spent, we'll just take just 2 questions. If we have any 2 burning questions so that we can wrap up this session and go into the next session. 2 questions for the presenters. Any? Okay, I'm seeing a hand up. Please, a mic. Oh, two. two. The directors are really fired up. Okay, please.
Yeah, thank you very much, Chair, and thank you the presenters for wonderful presentations. Since we've been limited to 2 questions, I'll ask only one, and that will go to my brother, Fred. Your last statement said that your commodity security is worsening in Bono East region. But the data you presented didn't really support that. And I said that because 2 new regions were created from Brona Hafo. And you are still sourcing your commodities from Bono. And if you look at Ahafo's commodity availability was quite high compared to Bono East. So I wanted to find out, why do we have that picture that Ahafo is getting commodities and you are not getting? Is it that the Bono RMS is not supporting Bono East as much as they are supporting Ahafo? Thank you very much.
Okay, let's take the second question from the director of Bono, and then we can wrap up.
Good afternoon to the presenters and everyone here. Well, Senior, my brother, I thought I was going to be acknowledged at least in the presentation for all that I've done for Bono East. Well, anyway, my question is that, for you to have commodities available at your stores depends on so many factors. And I believe some of the factors affecting commodity availability in the Bono East is actually the inability or the refusal of the facilities to reimburse the regional medical stores adequately. I think we've done this, we've gone over it already. And then they are penchant to procure outside the regional medical stores, even without non-availability certificates. So I think whilst you are going ahead in handling this, the system there has to be sanitized. So going forward, you need to sanitize the system there and make sure that to have commodities available at your medical stores, all those plaques has to be put in place. But my question is, why didn't you show the pictures of the meetings that we have been having and some of the outcomes? Thank you very much.
Thank you. I think we'll just take that 2 questions and...
Okay, in fact, Bono, they have supported us. Please, let's give it to them. Look, they have supported us immensely and having a good package for us. So there's a saying in Akan, so so we are really grateful for the support. They have supported us. I think what our council chair also said, we will look into all these. We will look into all what Dr. Amokodi has said. But the question is, why is Ahafo always in excess? We will leave the discussion, and as we go, we will discuss. Why is Ahafo having more than us? Senior will have to address that. But the challenge that I will say, and for which it's important that we go, is we believed in economy of scale. Look, from the onset, we decided we are not going to run medical stores. There's strength in numbers. And we wanted to be part of. For all along, from Elkin, our determination has been, we will be with the team. But the challenge has been the implementation of the declaration. most of the issues that Director Bruno is telling us were things that we were supposed to meet together as a team. Even we were supposed to put in that recollection team for all of us to do that. These were the things that the declaration really had for us to do. And these were the challenges. It's on that basis, that's why we have asked. This issue of procurement, if you look at the declaration, the last one I didn't show was that every procurement that Sunyani was going to do should consult Goso and Kintampo in doing the procurement. And all these are gaps, but these are the reasons why we will address. But Sunyani has been our pillar. He will continue to be our pillar. Thank you.
Thank you so much. I'll just make my closing remarks so that we can wrap up this session. I want to sincerely thank our two able presenters, Dr. Kwasi and Dr. Fred, for the excellent presentation, taking us through leadership. Just a few highlights, looking through the presentations, clearly leadership ability to influence is very critical for anything to actually move forward. And that starts with setting vision, as Dr. Fred is currently doing, and being able to also understand the impact of technology and financing, and not just the human beings, but appropriate and well-qualified human beings that will actually help to run the supply chain is very, very key for us to move forward. So I really thank the two presenters, highlighting the importance of technology, highlighting the importance of financing, but also looking at what systems can we put in place to sustain these beyond the one-off interventions. Thank you again. And for me, for my own closing remarks, looking at this session in terms of leadership, I think something that is very key really for all of us is being able to define our roles and responsibilities clearly and putting strong accountability systems in place for those roles and responsibilities we've been able to assign ourselves at the central level, at the regional level, districts, and at the health facilities. By so doing, we can continue to measure if we are making progress or not making progress on those accountability structures we've been able to put in place, and really continue to celebrate our wins, just like we are doing here. I often make a joke with people. When the supply chain is working very well, nobody notices. You think, the milk is just there. No, the milk doesn't just get there. Someone is actually working day and night behind the scene to ensure that you have the milk. But supply chain often gets attention when there are some disruptions. But if we continue to celebrate our wins and bring also our performance reviews up consistently, it's going to go a long way in encouraging the health workers, just like the organizing committee did, for the regions that won the award, got recognitions for the good work they are doing in Gilmis. Hopefully for next year, we'll start looking at other performance areas beyond Gilmis as a way of encouraging the health workers that they are actually doing so much and that their efforts are well recognized. And ultimately, really making sure that we have those appropriate incentives in place to recognize, but also to penalize those that are not performing very well. So they are not just left that way. I'm fine with being the last because nothing will happen. But making sure that we have the right incentives in place to penalize those that are not doing very well. By so doing, as a country, we can continue to ensure that our supply chain, as we know, is as strong as the weakest link, that those weakest links are always strengthened to enable us to move forward. So thank you again for being part of this session, and I will look forward to the next session in terms of supply chain dialogue. Thank you, and thanks again.
Let's do it better for the team. Thank you very much, Dr. Innocent, Dr. Daidonko, and Dr. Boateng for that. So the next activity is a panel discussion, and after that we'll go for lunch. So we should bear in mind lunch is between this discussion. After this discussion, that is where we'll be going for lunch. So I'll introduce our chairperson for this panel discussion. We'll introduce the moderator and other people. Our chairperson has been mentioned earlier on. He is the CEO of ASAS Pharmacy and Cosmetics Limited, both in Accra and Kumasi, the Chief Operations Officer for MGI Holdings, that is MGI Microfinance Limited, 2M Express Limited, and MGI Investment Limited, that is in Kumasi and Accra. Was a member of the 5th Ghana Health Service Council and a member of the Audit and HR Committee of the 5th Council. He has worked as Director of Pharmaceutical Services at Kindred Healthcare Systems, clinical and staff pharmacist at the Abbey Lincoln Memorial Hospital, practice resident at St. Margaret's Mercy Healthcare Center, pharmacy intern at Women and Infants Hospital and Pharmamerica, all in USA. Educational background: he holds a Doctor of Pharmacy degree, Northeastern University in the United States of America, a pre-pharmacy, Community College of Rhode Island in the US, diploma in German language from the University of Düsseldorf in Germany, BA Economics and Geography from KNUST. Distinguished ladies and gentlemen, I present to you Dr. Sifa Betiakon as our chair for this session. Please help me welcome him.
Good afternoon. Okay, since this panel discussion is between us and our lunch, let's try and keep up to the time. So those who are on other medications will be able to do that. Well, without wasting much time, I'll call on the moderator, who is in the person of Daniel Oswald Osu Afrani. Daniel Oswald Osu Afrani. Shall we give it to him as he comes forward?
All right. Thank you very much, Mr. Chairman. Because we are, getting closer to lunch, we'll be very fast. Good. So I'm happy to be invited to moderate this session. Can I sit down, please? Thank you. So we have Dr. Gustav Cruikshank. He's the Director of Finance, National Health Insurance Authority. Please, let's welcome him with a clap. We have Mrs. Emma Ofori Ajiman, Director PPME, Ministry of Health. So a representative is coming. Mr. Mustafa Adams Hamidou, Director Finance, Ghana Health Service. Elizabeth Williams, Health System Strengthening Team Lead, USAID. And we have Marasi Wencha, Senior Manager, Supply Chain, Global Fund. Good. Ladies and gentlemen, you are welcome. Good. So I will not dwell so much on the importance of supply chain in the health delivery system or the role of supply chain in the attaining the universal health coverage target. All that I want to say is that in Ghana here, we have a popular advert that says that water no get legs. It be interplus way the carry am. To wit, if you need water in your house, you need to have very solid and robust pipeline to deliver water to your house. So I want to borrow that kind of and indicate that health commodities do not have legs. It be supply chain functions they carry arm. to wait. Before commodities get to the facility, there are several functions that must be performed. And so I'm going to state some of them, and I'll ask some few questions. I consulted, or the team consulted a lot of people, and they have given me questions to ask you. So I'll just read their questions. But before then, there's a need for forecasting of commodities. They need to bring people together to determine the needs for the country. Somebody will have to pay for it. They need to build capacity so that people will be able to scientifically determine the needs. Somebody must pay for it. So the question is, who is paying for that? Another issue. Once you have identified your needs, you need to procure the commodities. Whether essential medicines, whether program commodities, test kits, all of them, they must be procured. Who is funding this? You need to also store the commodities, maybe at the central level before they are moved to the regional level and then to the facilities. Who pays for the warehousing? Not only the structure, but the systems in place, who pays for that? Distribution, we've heard about last mile distribution from central level to the facility, to the regional medical source, from the regional medical source to the facility. Who is paying for this? We talked about the need for a system that will generate, analyze, and transmit data in real time for decision making. Who is paying for that? You need human beings, human resource development for supply chain functions. Not only in terms of the numbers, but in terms of skills. Training, support supervision, and all of them. Who is paying for that? Then finally, you need to have supply chain coordination mechanisms at all the levels. Who is funding this? These are rhetorical questions that you know that. But let me jump straight to the questions. As I said, I'll read. So the first question goes to National Health Insurance Authority. We all understand the fact that health financing through the National Health Authority is very important, especially when it comes to payment for medicines and services provided to clients on the scheme. Now, from the resource envelope that the National Health Insurance Authority receives from central government through the 2.5% levies, and from premium of members, and based on the reimbursement that you provide to the facility, what are your perspectives for financial sustainability in the short, medium, and long term? The same mic.
Thank you very much, moderator. Health insurance is one of the flagship institutions for financing health care in Ghana. And we are a vehicle that is used to mobilize funds for healthcare financing in Ghana. And as such, when you come for a program like this, where the questions will come from, a lot of the times you have no idea. Health insurance, the questions come from anywhere. But I have to first and foremost extend my chief executive's apologies. As we speak now, he's away on a working visit to Germany. He couldn't come, so he called me last minute that I should come and represent him, so I'm here. And to answer your questions, I think the first thing that I'll be looking at when it comes to the short term is the timely disbursement of our funds from the Ministry of Finance through the Controller and Accountant General's Department. This has been a problem for some time now, but I can say this year, due to efforts from the minister and then others, we've been able to talk to, and then consistent meetings with the ministry. Now the releases have been coming slowly, and if you could see, some of the providers are here. The payments are also flowing to the providers. This actually causes a lot of challenges, especially when it comes to financing, because a health insurance not receiving the funds and for us to pass them on through payments to the providers do not only cause problems and challenges for the National Health Insurance Authority and the scheme, but also affect the providers as well. And then also we are looking at, in the short term, efficient claims processing. Efficient claims processing not only within the National Health Insurance Authority, but also at the provider level. Because what happens with the claims processing is that when it comes and there are errors and mistakes, what we do is after vetting, we have to deduct. And that deduction causes a lot of problems because you may be expecting some amount of money. And then what will come will not necessarily be up to that level. That will affect your budget and so many things. So we would encourage the providers to also enhance and train their claims officers so that the claims processing at that level will be efficient and effective. In the medium term, we're looking at a premium adjustment. The premium that our subscribers are paying now, it's about almost 20 years now. There has not been any significant increase. And what I mean by 20 years is we are paying 28 cedis for registration and then premium payments. And this was set, I think, in 2004. You could see the exchange rate now, the rise in exchange, inflation, so many. So this is actually almost negligible. But how to do it is a problem because it has a lot of implications on funding. So this is what we are looking at in the medium term. What can be done to ensure that we have a premium payment that reflects reality, that is also affordable for the subscribers to be able to pay. Now, in the medium term, we are also looking at revenue diversification. Now, the health insurance source of funding is basically tax-based. That is the National Health Insurance Levy. That is levied at you when you pay your VAT or you import your vehicles and whatever into the country. So aside that, without further tax burden, what else can we do to ensure that we have other funds coming into the National Health Insurance Scheme to be able to grow the fund? And this has to do when there was dialysis problem at Kolebu, or everybody, why don't you add it to the health insurance? Child cancers, why don't you add it to the health insurance? All of them. Now we cover about 95% of disease burdens in Ghana. But in adding them, we have to ensure that where we get the funding from, it's also expanded so that we can have more funding coming in to be able to finance the healthcare of our subscribers. Now we are also looking at, in the short term, what we'll also be talking about is fraud prevention. When it comes to fraud prevention, even our subscribers, some of them actually do what is called provider shopping. They will go to provider A, and then probably they don't like the facility or what the doctor gave them, then they go to provider B. And then, so by so doing, you realize that every visit actually incurs a cost. So how can we actually prevent this kind of abuse to the system? Also, at the provider level, there are some providers that also will take health insurance subscribers' numbers and also use them to actually churn out claims and submit to the National Health Insurance Scheme. It is difficult without proper IT systems to be able to determine, but sometimes some of them come out through clinical audits. So in the medium term, I think these are some things that we have to look at. Now, in the long term, we are looking at systemic reforms. So systemic reforms in terms of benefits package, the payment systems, and overall healthcare financing structures of the National Health Insurance. The benefits package that we have now, is it okay? Is it effective and efficient for healthcare in Ghana? How about our payment systems that we have? The increasing of our tariffs year on year. How are we going to go about it? These are all issues that I think we should be looking at in the long term. Also, we should be looking at the general public health, which we term it population health management in the National Health Insurance Scheme. If the population is healthy, going to health, the facilities will, of course, reduce. At the primary care level, everything will be fine. But once it goes to the secondary and the tertiary, the cost shoots up. And sometimes when it shoots up, it's not easy. It's about 10, 20, sometimes even 100 times. The other time we were at a place with, my colleague was there, and we were talking about preventive health care. and one of the doctors was talking about cervical cancer and testing. And that when you test it now, it will cost you about 100, 200 cedis. And when it is actually diagnosed early, something can be done about it. But if not, and it shoots up to the cancerous level, then the cost also shoots up to the roof. So these are some of the things that I think in the long term we have to be looking at. Now also, how about technology integration? Linking the national health insurance data systems with that of the providers, so that when a subscriber or a patient visits a particular facility, the claims that is churned out right from the doctor's room to the pharmacist will come straight to the national health insurance. And then we can also quickly at the end of the month reimburse the providers without actually they having to carry their claims all the way to our CPCs, and then we have to vet when they bring them and then go through the system before we pay. Another thing too that we are looking at in the long term about integration is that, how about if each and every one of us has a card or something that when you go to the facility, your health history should be able to pop up from either your Ghana card or the National Health Insurance card. That will also help in actually the physicians know exactly how to treat you. Instead of try and error without experience, a lot of them will rather increase cost than actually to manage the cost. Now we are also looking at public awareness and then participation. And this, the Health Insurance, National Health Insurance Authority, we think is important because we have to make our subscribers and everyone a partner of the National Health Insurance Scheme. The National Health Insurance Scheme belongs to all of us. And we think that everybody should be able to participate in the decision making, in the welfare and the goodwill of the National Health Insurance Scheme. And by so doing it, to go a long way for Ghanaians to own it, that this is for us, this is good for us. And in the long run, it will help to sustain the National Health Insurance Scheme. Of all that I said, if all of them are implemented, even up to 70%, it will go a long way to help finance the supply chain that we're talking about. Because once we pay the facilities in time, they will also go on to also pay their suppliers. And those in between will all have the funds necessary to be able to do what they have to do to ensure that the healthcare system in Ghana is working as it should. Thank you very much.
Thank you very much for your comprehensive response. The plan had been to ask each panel member 2 questions, but your response has delved into the second question because we were going to ask you, based on the bottlenecks that you have now, what measures, innovative measures you are going to put in place to ensure that the health of the National Health Insurance Scheme is sustained. But you've answered that, so we'll go around. At the end of the discussions, if time permits, we'll just agree to ask the audience to ask just 3 questions, if time permits. So, Dr. Eric Nsia-Boateng is representing the Director at PPME. He is the Deputy Director at PPME, Ministry of Health. So, as a division for policy coordination, sector-wide planning, sector-wide budgeting, and resource mobilization, what strategies do you have in place to ensure sustained financial support for implementing supply chain interventions, including procurement of critical medicines for public health programs, malaria, HIV, TB, maternal and child health, and family planning?
Thank you very much, Mr. Moderator, for this opportunity. At the national level, the ministry, together with the agencies and partners, have put together, as we are all aware, the supply chain master plan, which we are implementing. But we have several interventions, or if you like, strategies in that document that we want to, together with the partners, try and implement them and address some of the bottlenecks that we have. So one of the strategies will be the coordination and collaboration. It's something that we cannot do away with our development partners. As we speak, we've had discussions with the Global Fund, the Gavi Alliance with respect to the vaccines. We are in the transition period from 2024 to 2029, meaning that in 2030, we need to begin to self-finance some of these commodities. So as we speak, we are developing a roadmap as to how best Ghana can self-finance some of these commodities. So coordination and partnership will still continue. And in this arrangement, UNICEF is serving as the agent for the procurement so that we get a competitive pricing for some of these things. And in the transition period, we will continue to use that mechanism. There's also a talk that we need to discuss with government. If you look at NHIA, there's a capping policy. And NHIA also gives money, at least 10% of their annual revenue to the ministry for preventive services, which also includes the purchase or procurement of commodities. So we need to discuss with government and see how best they can also, if possible, that is what we ask, that NHIA can be taken out of the capping basket so that it gives it fiscal space to give more money to the ministry to be able to do this. As you mentioned, some of the programs like TB and malaria are being funded by Global Fund, and something that we will continue to do. There's also a talk with some of the DPs on the revolving fund. It's something that we've been using in this country. We used to call it drug fund. Recently, we had a discussion with USAID. They've expressed interest to continue to help us to also strengthen this revolving fund so that we have a sustained funding for these health commodities. Other partners have also shown interest, and we believe that this is also another intervention that can be used to provide continuous funding for health commodities. The other bit that the government or the ministry is also looking at is partnership with the private sector. I mean, recently we are all aware that government, together with a private manufacturing company, the Atlantic Life Sciences, yes, they have begun the production of some of these commodities. They've started with the anti-snake venom. We've also set up the National Vaccine Institute to also promote production of some of these commodities. So that it's not always that we need to import these commodities from outside, which is also costly to the government of Ghana. And then using the framework contracting tool, we are also giving, if you like, leverage to the local pharmaceutical companies to also procure or produce and distribute some of these essential medicines on that list. And we believe these things will also reduce costs to the government of Ghana. So these are some of the things that we are doing. They are not all. I think there are also other efficiency measures. The various presenters mentioned some of them. The last mass distribution, the governments, these are the logistics information management systems that we believe can also help us cut down cost or improve efficiency in the production and distribution of health commodities. So I think I'll stop here, and then later we'll add to that. Thank you.
All right. Thank you very much. So please kindly hold the mic because I'm coming back to you. Before I get to you, Dr. Mustafa, you mentioned efficient use of the revolving drug fund. I'll ask, but you also talked about the private sector. So there are several supply chain functions. For instance, when it comes to warehousing, even distribution, and let's say games. Do you have any plans to partner, the private sector to support in the implementation of some of the critical supply chain functions? Do you have any plans for that?
Yes, we do. I mean, if you look at, for example, the zip line services, one of the interventions in the plan is to make sure that we also make use of some of these things. I mean, drones for distribution of some of these commodities. And zip line is one of the examples that we can give. And we will not end with zip line, sorry. We will also look for other private, entities who are also into this space, who can support the government when it comes to distribution of some of these commodities to the district or to the facility levels. So if you take the master plan, the supply chain master plan, we have some of these interventions in there. Thank you.
Thank you very much. So, Dr. Leonard Anaman, all right. representing the Director of Finance. Thank you very much. So, how do you assess the level of transparency and accountability of the financial management systems within the health sector as they relate to supply chain management? Please, in answering this question, indicate, if any, the existence of any technology-driven solutions to streamline procurement, distribution, and inventory management processes. The question again. All right. That reminds me of something. I will not say it here. So the question is, how do you assess the level of transparency and accountability of the financial management systems within the health sector as they relate to supply chain management? In answering this question, please indicate, if any, the existence of any technology-driven solution to streamline procurement, distribution, and inventory management processes.
Well, thank you. I think the game changer has been the introduction of the GILMIS in the management of the supply chain value system. And so when you look at the introduction of that system, it has brought some considerable improvements in the accountability of commodities, as well as the transparency that it requires when managing these commodities. What we, however, find a bit more challenging with the system is the inability to comprehensively allow the financial management system to be reported as an integral component of the software. And so we are in the engagement process with the developers as to how we can have that architecture incorporated in that software. But all in all, one can say that we have had a very significant turnaround when it comes to the issue of accountability of commodities as far as our supply chain management is concerned. And we can also say that has furthered the transparency agenda of the service when it comes to the issue of supply chain management. I think going forward, we are interested in making sure that the GILMIS becomes a one-shop software such that we can drift away from our legacy systems of reporting to now leveraging on the GILMIS for the composite reporting as far as the supply chain management is concerned. We must remember that it is mandatory under the ATF to report on stores accounting. And so if we are unable to leverage on the GILMIS to do so, then it delays our ability to provide management with the timeliness of information for critical decision making when it comes to critical areas such as the supply chain management. So all in all, there has been considerable transparency and also considerable accountability as a result of the introduction of the GILMIS. What we may be praying for is that as we engage the developers, we will be able to have the opportunity to incorporate some of the areas that we believe can enhance the operability of the software.
Yeah, thank you very much. So, please, another question for you. Kindly share with us any measures put in place to safeguard the use and maintenance of the revolving drug fund and IGF. I mean, accountability in the use of the revolving drug fund.
Well, first and foremost, we must remember that the Ghana Health Service has come a long way in terms of providing some checks and balances when it comes to the utilization of internally generated funds. Over the years, we've had issues of infractions that have come from facilities as a result of the fact that management of these facilities have not been able to take into consideration the need to safeguard these resources for the direct core delivery of healthcare services. And so these were challenges that we had over the past years. And so we had to also align ourselves with new contemporary challenges and see how best we can address some of these issues with the necessary assertiveness that it requires. And so you could realize that over the few years, we came up with the IGF utilization policy that was intended to provide certain regulations or certain guidelines as to how the utilization of IGF is supposed to be carried out. And so the emergence of this policy has brought the need for these facility heads to now pay attention to the fact that you cannot, provide services, by violating the key areas of revenue generations that are supposed to be safeguarded, especially for direct core services. And for example, what we mean is that if you are providing services and you know that drug account is meant to strictly ensure that drugs are procured for the good cause of the service delivery, you are not permitted by the policy to by picking or seeding some of these funds for other activities, because those things are prevented or avoided from being implemented under the policy. And so there are sanction regimes also accompanying this policy, where we expect that the regional directors will support the management of Ghana Health Service in ensuring that compliances, are, enforced at the lower levels. Because if we don't get the compliances from these facilities, what we are going to have is that we may have the policy in paper, but we may not achieve the intended outcomes. And so the aspect of the enforcement is so critical for us to be able to achieve the intended aim for which that policy came into being. We must also remember that, for example, over the years, even beyond this particular policy, when you take the issue of the drug management, we had incorporated in the ATF the need for every drug expenditure never to be incurred without the involvement of the pharmacist in charge at the facility level. This is a control measure to ensure that the drug account is not, violated. And so these are some of the steps that have been taken over the years to ensure that we safeguard some of these critical areas of resource accumulation for the direct purpose of service delivery for the good of the people.
Thank you very much. So, USAID, Lisbeth. So, what has been your contribution towards financing the health supply chain programs in Ghana? And what is your outlook in the future in terms of the country development cooperation strategy that guides USAID investment, bearing in mind sustainability, and the government says Ghana beyond aid, but you say journey to self-reliance?
Right. Good afternoon. I recognize that I am between you and lunch, so I will keep this very short. And hopefully if we have some additional comments and questions, then we'll be happy to take them. So actually a lot of things that I had in mind are some of the things that some of my other panelists have mentioned. So I'm really honored to be in the company of such esteemed panelists. USAID's investments in supply chain on an annual basis is about 20 million a year. And it cuts across several different areas. And I think a lot of people here in this room are here because in one way or the other, they may have partnered with USAID or donors like us in one way or the other across the supply chain. We work across policies, supporting policy development, the national supply chain master plan. Policies beyond the national level, we're also looking at expanding them now to go to the regional level to look at strategic plans at the regional level. That's the next part that we want to emphasize. We work with data as looking at working with the Global Fund to establish GILMAS, and not just the establishment of it, but actually look into utilization and ensuring that it actually happens. We work with commodity procurement, which in some of the areas, especially related to the malaria programs, we supply a lot of long-lasting insecticide-treated nets that are distributed on an annual basis. But I think above all of that, I think probably the most important thing that we do, and in my estimation, probably the most impactful thing that we do is capacity sharing. And I don't say capacity development because I think it's a misnomer in a place like Ghana. A lot of the people we work with are people who have taught and learned and in the same environments that I grew up in, or in environments that anybody from the United States grew up in. So the capacity exists in Ghana. We're not building capacity here. I think what we really are doing is sharing, because we're looking at what you are doing in Ghana, at the regional level, at the national level, at the district level, and we're using some of the information that we may have from some other countries that may have similar circumstances as this, and looking at how we can share that capacity. And to develop, with the goal to develop something that is better than what we have, what you currently have, and possibly what we have already from some of the places that we have experience in, to the benefit of what Ghanaians will have. And I think ultimately, when you look into what our current CDCS goes until, our country development cooperation strategy goes until 2025, most of the things that I have outlined here will not necessarily change. One of the key areas that we do, one of the key areas of sources of information when we develop any strategy in any country that we work in is to look at the existing national plans. And as long as you continue to work with your supply chain master plan, we will continue to fall in line with that. So the leadership of the government of Ghana, either through the Ministry of Health or through the Ghana Health Service, or we follow the lead of you, the National Health Insurance Service, to ensure that what we propose, what we work with you on, is a true partnership, and that's fundamental, will not change. Yeah.
Yeah, thank you very much. Marasi, similar question to you. What has been your contribution towards financing the health supply chain program in Ghana? And what is your outlook in the future in terms of supply chain investment plan in the next grant cycle for Global Fund, bearing in mind sustainability and the journey to self-reliance?
So thank you, Daniel, and thank you, my fellow esteemed panelists. Like Elizabeth said, a lot of what I had planned to mention has already been said here, so I'm going to be very brief. And perhaps what I'll do is focus more on numbers, because a lot of the solutions have also been mentioned here. So for everyone's benefit, I think you all understand Global Fund has different funding cycles, which tend to be 3 years. We are now in the grant cycle 6, GC6, which ends December this year, and then next year we start GC7. To give you a context of scale, in GC6, Global Fund's financing for system strengthening, HIV, TB, and malaria was $238 million. We're expecting a largely similar level of funding going into the next cycle. Now, if we look specifically at health product or supply chain related investments, which includes products as well as system strengthening, in GC6, if we look at just HIV and RSSH, That was in the region of around 131 million, or 75% of the total need articulated. Government of Ghana's commitments were around 14.5 million, or around 6%, but that overall gap from what was projected to what was needed was around 19%. Let's fast forward to GC7, Health Product Management investments. So for health product investments, what the current projection is 223 million from Global Fund, which will equate to about 65% of the total need of the country. Again, the government's commitments are about 51 million, but the gap that is on the table today is around 16%, or 48 million. Now, a lot of what we've discussed today is around, what are we doing around warehousing, what are we doing around information systems, and last mile distribution. To give you an extent of the funding that's going to go into those areas, for warehousing, about 5.8 million, distribution, 4.5 million, information systems, 1.3 million, but for Gilmis, it's important to note that between GC6 cycle, GC7 cycle, a total of about 7 million has been put there. So as you see from the numbers I presented, there's obviously a large scale of investment that comes from the Global Fund, which is a partnership that includes many different actors. But the scale of the gap is also huge, right? And I think your question, Daniel, is how do we transition that? How do we do that well? So within our supply chain strategy, one of the key objectives that we've set forth is around investing in country-led efforts and stewardship that is going to support the journey to self-reliance, sustainability, as well as resilience of supply chain systems. That's a core fundamental, and I think very much a theme of what we have discussed to date. But there's two things which we say within Global Fund as being absolute paramount for ensuring sustainability of financial models. One is, what is the government's progressive investment and expenditure towards this specific area? So in this case, we're talking about supply chain investments. And then secondly, even within that area, is how are we increasing the uptake of specific program costs as they pertain to supply chain? So again, government's progressive expenditure and then specific program-related costs. How do we increase that as well? And a lot of what my esteemed panelists have discussed is what is already happening. Now the key is how do we accelerate that, right? Because Elizabeth talked about master plans as being paramount. There was a lot of conversations also around sustainability strategies that Dr. Araba talked about earlier. All of these are already happening. But from my perspective, there's about 4 that we needed to highlight. And again, I think my colleagues from the Ministry and NHI have talked about that. Number 1 is increasing domestic financing. What efforts can be done around that? The example of RDF expanding it to program commodities outside of essential medicines is one such example. Number 2 is around public-private partnerships, and my colleagues have also touched about that in terms of how do you use the expertise for efficiencies, how do you use that expertise for also introducing new areas and partnerships and capacities that don't currently exist. Number 3 is around effective and cost-effective procurement strategies and frameworks. We talked about our the contract frameworks. How do we make sure we're establishing that for ensuring we have efficiencies in purchase pricing, volume guarantees, etc. And then last but not least is around health insurance schemes, right? And all the points that my brother over here talked about in terms of premium collections, diversification of funding resources, efficient claims processing. All of those are options on the table that I think the key is how do we accelerate that and use that revenue to be able to fill in the gaps in all those areas of programs as well as the services of the supply chain.
Thank you very much. I think you all agree with me that we've had very constructive and rich discussions here, and my hope is that those who are taking the notes will try and summarize all of them so that we'll be able to follow up in terms of the key next steps following this. At this stage, Mr. Chairman, if you permit me, just ask, just 3 questions, and then we can wrap up and go for lunch from the audience. People are hungry. Any question from the floor? It seems they are okay. Yeah, so exactly. So Aside all that we've discussed, what will be your final recommendation to improve supply chain financing within the public sector? In summary, just a minute each. There's a question?
Yes, thanks so much. I want to link the presentation by the NHIA rep. He had a wonderful suggestions, and I think that talking about long term, the ability to link up the NHI claims processing from the facility to your end is wonderful. That will mean that there's real-time data. Right. We cannot end it there. From today's presentations, we also see the gap between GLMES and the end user. We give awards to people, facilities that are doing so well, but I can tell you, I moved from the facility, I can see the sacrifice that those people made to get that. I mean, to sum up all this, can we look at linking the GLMEX to the end user such that whilst they are working real time, if you're at the pharmacy, the medications have come, you must receive them into your system before you can dispense them. That will be automatic. You cannot compromise that. Once you don't receive them to the system, you can't work, you can't dispense. And once you are dispensing, let's link it up. I read to talk about finance, internal generated funds. Whilst you are working with this, NHIS, you are dispensing, the internal generated funds is also taken care of. So you have a total system, one-stop shop that is solving so many of our problems. I think that's the way to go. Because as human beings, if we don't put such a system in place and work in silos, as a nation, is going to be very, very difficult. Some will do well, some will not do well. And those that are not doing well may be many, and the system will still what? Crash. Thank you.
Thank you very much.
Yeah, thank you very much. My name is Kwame Mpedueje. NHI, for long-term sustainability, I think 13 years ago at Akroma Plaza Hotel with Dr. Chunebua, some of us made this suggestion that you should work towards ring fencing that 2.5% so that that money is always available for you to use. He said the idea was laudable, but for 13 years down the lane, nothing has been done on this arrangement. And if we want the NHIA to succeed, the long run, please, let's work towards how that 2.5 can be ring-fenced so that we can have access to that money. Thank you.
Thank you. One last question.
Thank you very much. My name is Felix Edwapari. And please, I want to find out, these days, our health facilities have been taxed to pay for electricity bills. And then even including the cold rooms where vaccines are kept, they are supposed to pay for these bills. My question goes to NHIA, whether they have any plans of helping us to absorb those astronomical bills that are coming up, that we are struggling to pay, because they form the basis for the supply chain sustainability we're talking about. Thank you.
NHIA, I don't envy you at all. Everything is being piled on you. So you may take the opportunity to answer that question and then bring your conclusion remarks. Maybe we'll go around just a minute each, and then we can wrap it up.
Yeah. Thank you very much for the questions. I think these are relevant and very important questions. I want to thank our brother there for the suggestions of actually properly integrating the system so that information and data flow will flow through each and every event area or every decision-making area. That is well taken note of. And also about the ring fencing of the 2.5% that we talked about some 13 years ago ended up in we actually being included in the capping. So it is beyond NHI. It is even beyond our minister. This has to do with the Ministry of Finance and then controller. So we don't really have much control. What we can do, as we are doing now, is to properly lobby and to make our case properly clear before all the decision makers so that they can take care. What we are working out to do now is to get out of the capping. Because if we are capped, the Ministry of Finance will not get their money. We will also cap them. And then the money that comes to the claims, we might not be able to meet them when they are due. So that is what we are working on. And we pray that will be successful. And in saying that, I think I will end my comments here by saying that what we have done to help in this supply chain management is that now when you go to our website, especially the public providers or facilities, our claims payment to all the public facilities is now published on our website. You go there, you type in a particular facility name and then the district, you should be able to see the claims that we have paid to that particular facility up to which month. Initially, we had some of your colleagues come in and say, you know, when you publish it, the suppliers will come and chase us, you know. And we said, no, once we have paid you and you are saying, we have to publish it. The only caveat is that the private sector, we have given them a password that they will go and check, which is the private sector, is their private business. But for the public, we have it published. And also another thing for the public is that because we want to ensure that the supply chain is working, what we did was to now divide the claims between the services and the medicines. We used to combine them as one, but now we have the services and the medicines. And the medicines, I don't know if it's still into it, but we remember that the DG some time ago actually sent a directive that the medicines portion should never be used for any reason. It should only go into medicines. So that is what we have also done. We've been able to adjust our systems to divide them. So when we are paying to the public sector, you could see that we have the services, and then we also have claims for the medicines. And now what we even doing is that we want two accounts, one for the services, and then we'll pay the medicines one straight into the medicines account. And when it happens like that, now you have the... I think I end here. Thank you.
All right. So thank you very much. Now you have the mic, so you can go.
So thank you very much. I think with respect to the financing, in the long term, what the ministry is looking at is to at least have 50% of the health budget dedicated to primary health care. I mean, we all believe that it's a vehicle to achieving the UAC target. So that's a long-term measure, that the health budget, at least we should be able to allocate 50% of that to primary health care. We are also trying to develop the IGF guideline. We saw from the Bono Regional Director's presentation what he is doing in his region, and I believe it's from IGF. So we want to develop this guideline to guide them so that they can also use part of the money that they generate to finance some of these things. And I think recently we developed the health financing strategy, which we are implementing. So all these things, all these policies are also meant to improve financing of some of these communities. Thank you.
So two very quick points. I think on Gilmes, very much agree with the comments mentioned there. And I think beyond extending to finance, I think also dispensing is going to be absolutely key for Gilmes. I think there's an adage that says you can't improve what you don't measure. So I think the challenge now to everyone here is how do we measure what that gap is in terms of what needs to be financed more by the government of Ghana, and then begin to gradually employ all of the different solutions mentioned today to close that gap.
Okay, now I'm really between you and lunch. I think the last thing I would say is Ghana does have a lot of good policies, and I think you also have a lot of good leadership in place. I think the one thing that is possibly missing from my end that I see is possibly a common thread across the board is demonstrating that leadership in ways that improve accountability. And that accountability could be in relation to data management or use of data for decision making, or it could be in ensuring that your drug revolving fund is ring-fenced and actually used as it should be. And the accountability measures shouldn't be put in place as punitive measures. It should be put in place in a way that facilitates the work that people do on a regular basis, such that it flows into their regular work day and it becomes the default option. If it takes me as a data entry person or a health worker additional effort for me to fill orders into Gilmus as well as fill in consumption data into Gilmus, while there is another system in which I have to put in prescriptions and filling of prescriptions at the pharmacy level, it will become, the onus is on me then to make that time to be able to fill those two systems. And I think that is not a solution that needs to happen at that level. It is a leadership solution. And that demonstrated leadership that helps, whether it's accountability for financing or accountability for data entry, really needs to be shown. And I think irrespective of what else we do, if that is not demonstrated, we will be talking again in the next 13 years, like our colleague mentioned earlier, about some of these issues. And I hope that is not the case.
Thank you very much. I think for us, as Finance Directorate and as Ghana Health Service, one of our core desire is to see to the drift away of our regional medical stores from the state of insolvency to a state of solvency. And one of the key drivers of this is to leverage on managerial accounting and cost accounting for the purposes of injecting efficiency, effectiveness, and control of cost at those levels in the management of these stores. And so when that happens, I'm not sure we would be here listening to Dr. Dumakun talking about setting up an ad hoc committee to now advise him on the state of indebtedness and to know how to settle those debts, because once the managerial accounting and cost accounting is fully functional, we expect the various regional directors to be apprised with all the necessary information for critical decision making, and that would prevent them from setting up ad hoc committees for some of these things. And at the lower level, we also expect this to translate into efficiency in the usage of commodities, because one of the key drainage of their resources that is making them not to be able to pay the regional medical stores is the flagrant abuse to the usage of commodities at that level, and without the ability of these facilities to even anticipate the necessary control measures. And we believe that this managerial accounting is there to support these facilities to bring some form of efficiency controls in their management of commodities. And so all in all, we expect some level of drift away from our challenges that we are facing, especially with our regional medical stores, to a level where we believe that we can make these regional medical stores profitable and make them more functional for the required support to the clarion call for an effective service delivery to the people of Ghana.
Thank you very much. I will not attempt to summarize what has been discussed here. The only comment I will make is that let's not end it here. Let's take the conversation outside. I believe at the end of the day, we are going to have a communique. Let's put it in a manner that we'll be able to send it to the appropriate quarters for the decisions to be made. So on this note, I wish to thank my panelists for availing themselves and for enriching us with good ideas. I'll hand over to, and then thank you very much for your participation and for giving me the opportunity to moderate this session. And then I'll hand over to the chairman for his closing remarks. Then we can go for lunch. Thank you. So he's not just the chairman, but chairman for the Ghana Health Service. Thank you.
Okay. Thank you very much. What I would like to remind ourselves is that this panel discussion was titled Achieving Sustainable Financing for Ghana's Public Health Supply Chain for Universal Health Coverage. That is what our panelists has been discussing. We have talked to partners, we have talked to Ghana Health Service, we have talked to the Ministry of Health, and we've all talked to National Health Insurance. All of them have given us strategies to be able to sustain our financing going forward. If we're listening to our partners very well, some of them, their focus for this coming cycle probably will not change. But if you look at our portion of it, there still remains a gap. So it means that we have to have a lot of work to do. So National Health Insurance, USAID, Global Fund, and all that, like our moderator said, we will not try to say, although we have everything here, we will not try to summarize it at this point, but it means that it still remains that a lot of work needs to be done. We as a service, we need to do our part. Our finance department is doing their part in terms of management accounting and also the guild systems and all that. Also, Ghana has also come up with the GANEP, which will also help us with the visibility in terms of procurement and all that. I know the procurement department is working on these things, and eventually it will be full-blown so that everybody will know. The visibility will be very clear. So we're also working on that as well. Anyway, so with this, I think we will discharge ourselves and go and have our sugar bust. And we thank you all for your participation and also your support. Thank you.
Thank you very much. Please let's clap for them as they are taking their seats. Thank you very much, Council Chair, for chairing this session, and as well as our moderator. Thank you. Please, we've ended our lunch. Make sure you have a lunch coupon. We are all going to the African Village Restaurant for our lunch. But from lunch, let's take note of this announcement. Please, let's take note of this announcement. After lunch, we are not coming here. We are going for the breakout session. We have 2 syndicate rooms. We have 2 syndicate rooms. The room 1 is on the topic Innovations in Healthcare Supply Chain Management, and this will be at Kundum Room. It's on the first floor, Kundum. Innovations in Healthcare Supply Chain Management. If you are interested in this, please make sure that you join them at Kundu after lunch. The second one is Public-Private Partnership, PPP, and this will happen in Odra Room, also at the first floor, and this is going to be chaired by Dr. Mrs. Akosua Ajewa Owusu Sapon, Regional Director for Greater Accra Region. The first one, Innovations in Healthcare Supply Chain Management, is going to be chaired by Dr. Winfred K. Ofosu, who is the Regional Director for Eastern Region. Please, let's take note of this. So it means from lunch, we are not coming here. We are going straight to our syndicate rooms of our choice, after which I will come and call you for the plenary before we close from here. So please enjoy your lunch. If you haven't registered electronically, please do so for us. Yes, the lunch is 45 minutes, so we are coming back here at 3:45, exactly 3:45. Please, let's take note of that. So that we are not coming here, we are coming to our breakout session, syndicate rooms, after 3:45. Please, let's take note of that. Thank you. Enjoy your lunch. The lunch is at the African Village Restaurant near the seaside. Please get a lunch coupon before you go. Thank you.